This talk is entitled Innovative Simulation Training and Radiology Residency. It was put together by myself and my colleague, Associate Program Director of the Radiology Residency at Wake Forest, Scott Wurtzer. We have no disclosures. The objectives will be to present a plan for starting a radiology simulation lab, including funding the equipment for the lab, finding an optimal space for the lab, establishing teachers, and designing a lab curriculum. For clarification, simulation training is no longer an innovative concept. In fact, there are numerous articles and even textbooks on the benefits of simulation and residency training and on how to do it. In fact, there's even a great radiology text. It's just simulation in radiology. So if this is the case, why aren't all of our programs doing robust simulation? Well, it's kind of like this cartoon. We start out, it's a great idea, can't wait to get started, it's going to be awesome, and then you start to do it and you find out the equipment's expensive, it takes a lot of manpower and time, I might fail. Then you start looking up what simulation labs look like and you get this, and you realize, wow, got robots and fluoro, and you look at the costs and you say, gosh, I don't have any money, I can't afford this. And quite frankly, most of us can't afford that. So while simulation training itself is not a new or innovative idea, we can be innovative in how we put together a simulation lab when we don't have any money, equipment, space, or manpower. Sound familiar to anyone? So we're going to focus on where we can make an impact first. We're going to go for simulation that's going to help the masses. We're going to focus on common invasive procedures that all general radiologists should be able to do well, including ultrasound-guided biopsies and drains, fluoro-guided spine and MSK procedures, and contrast reaction management. Because the reality is, studies have shown that more than 50% of invasive image-guided procedures are performed by general radiologists, not interventional radiologists. Most of these cases are lower complexity, and if we don't continue to prepare diagnostic radiology residents to do these cases well, we're going to be contributing to inequities in healthcare delivery. So we're going to do simulation. We're probably not going to be able to start with this. We're going to have to start with equipment such as this. We're going to need an ultrasound machine, but most of us won't be able to afford a whole fleet of ultrasound machines, so we're going to use tablets just attached to ultrasound probes, which are cheaper. We're going to need phantoms. We're going to need some high-fidelity company-made phantoms and low-fidelity homemade phantoms. We're going to need needles, biopsy guns, drapes, and towels. This is an example of our fleet of equipment in our starter sim lab. We have a very nice new ultrasound machine that we bought for the lab. It stays in the lab all the time, but we could only afford one of these, and we want to have more than one resident working in the lab. So to save money, we also bought some of these probes, ultrasound probes, that can be attached to tablets. These are actually very good high resolution and good image quality, and they're cheaper than the ultrasound machine. This is our set of high-fidelity phantoms. We started with phantoms for common procedures. This is our vascular access phantom with the red artery and the blue vein. This is our kidney phantom, our liver phantom. We have thyroid biopsy phantoms and breast biopsy phantoms. We also use low-fidelity or homemade phantoms in our lab. These are cheaper, and sometimes they're a lot better, quite frankly, than the high-fidelity phantoms. This is a 3D spine that we printed and embedded in ballistic gel in our kitchen so that residents could practice fluoroscopically guided spine procedures like lumbar punctures. There's actually it's very good image quality, works really well for practicing these. This is an example of our raspberry gelatin breast with olive, grape, and sweet potato tumors in it. There are recipes for making these breast phantoms all over the internet. We will tell you that a lot of these recipes tell you use plain gelatin. If you use plain gelatin, it will stink up your kitchen for about a week, so we recommend the flavored gelatin. This is a raspberry gelatin breast with a balloon breast implant and olive tumors. We've got this recipe off the internet. You make it, you just flip it over, and the residents can practice biopsying tumors around a breast implant using ultrasound. This is the water-filled glove as an abscess needing a drain. You can have the residents, with one of our residents, practicing putting a drain in the abscess, and the gloves in your fingers serve as the bowel floating around the abscess. You're going to need some biopsy equipment. You're going to need needles, biopsy guns, catheters, and you may need to be innovative here. We put out a storage bin for expired or dropped equipment in our breast imaging and IR areas and collected a lot of equipment that way, and then we purchased a set that could be used over and over of things that we couldn't collect. You're going to really need all the different types of biopsy and needles and guns that you use in your practice for simulation. This is Dr. Lee, one of our breast faculty, teaching Jordan, one of our residents, the different types of guns that we use for breast biopsy in the lab. You also need to have all the different types of freehand needles and guides. Again, the residents need to feel comfortable with the equipment in the lab before they're in front of a patient having to use the equipment. Now that you have equipment, where do you put your lab? Well, quite frankly, you put it anywhere you can find. Start small. An abandoned small office or a big closet will work for this. We had an office that wasn't being used well, so we store our equipment in there because it does need to be locked up. And then right outside of this office was a study space that was being underutilized, and it was also a file cabinet storage place. We decided to use that as our sim lab. You can be innovative by borrowing from your friends. One person's trash is another person's treasure. Our OBGYN department was throwing away these exam tables. We said, hey, we could use these in our lab to do the biopsies on. So we took them. We had to clean out these drawers. I don't want to tell you what OBGYN was storing in them. It was disgusting. But we did clean them out, and now we have great tables to practice our biopsies on in our lab. So how do you pay for all this? Well, you may need to be innovative in getting the funding, and you may need to rely on your friends. Some institutions and departments have educational funds that you can use for this. We didn't have any of those, so we got innovative by going to our alumni. That's the Radiology Residency and Fellowship alumni of our program. We established an alumni educational society with the help of our development office, and all the alumni contributions for the society are used to fund educational endeavors for the residency, and it funded our entire simulation lab. So you have equipment, you've got a space. Who's going to teach in the lab? Well, you're going to have faculty, but some programs are small and you don't have a ton of faculty available to teach in the lab, so you can be innovative here by training senior residents and fellows to help teach and tutor in the sim lab. We call them super users at our place, and they are indeed super. You're going to need a sim team of faculty with representation from breast, abdomen, neuro, MSK, and IR to help run it. And this is one of our breast imaging faculty teaching our resident super users how to teach other residents how to do ultrasound-guided breast biopsies. So we have a larger fleet of teachers in the lab in addition to our faculty. So you have equipment, space, and teachers. Now what? Well, you need a curriculum that's tailored to the needs of your residency program. A single curriculum does not fit all. You need a logical curriculum that's going to provide simulation training pertinent to the rotations the resident is on. Timing is everything here. For example, a resident needs simulation training for breast biopsy immediately before and during their breast imaging rotations. Here's a sample of our simulation educational curriculum. We do ultrasound, intro to the ultrasound machine and scanning for our first years in August. Then we'll do an all-day simulation lab in September to introduce all procedures and simulation equipment to the residents. We have all our residents rotate through this, and it's a good introduction to the junior residents and a good refresher for senior residents. We're going to do ultrasound-guided breast biopsy, vascular access, abdominal biopsy, and abscess strain placement monthly in the lab for residents who are about to go on those procedures. We do fluoro-guided lumbar punctures for our junior residents in July and August, and we're just launching fluoroscopically guided hip aspiration, which we'll do every 2 months for our residents rotating onto advanced MSK. These sessions are usually 1-hour sessions led by faculty who specialize in that procedure. We usually have 2 to 4 residents in each session, and the sessions are scheduled on days which work for the faculty based on the faculty's schedule. So we'll have a breast faculty if we have a group of residents who are going to be rotating onto breast imaging. We'll schedule them with our faculty for a breast session in the lab. Based on the faculty schedule, we'll pull the residents off of their daytime rotation for an hour to the lab. Most faculty are fine with the residents leaving for an hour, and then they work with the breast faculty prior to and during their breast rotation. The logistics of this are the program director and, importantly, the coordinator handles the scheduling of the sessions. We're the ones who know what rotation residents are on and who's about to go on to rotations which need simulation training. This is an example of one of our abdominal faculty teaching first-year residents ultrasound scanning in the lab and introduction to the ultrasound machine in the lab, which we do in August. This is some images from our all-day simulation day with stations using all of our equipment. This is our breast and thyroid station, our liver station, our kidney station. This is our abscess drain placement station and our vascular access station. Each station is 15 minutes, and all residents rotate through each station that day. Sometimes you can be innovative with partnering with other departments. OBGYN and emergency medicine often have some similar simulation needs to radiology. In fact, our OBGYN physicians had created an ultrasound needle guidance skills trainer to help with targeting lesions, and they were happy to share that with us. It's important to have these small sim sessions timed to when a resident's on a pertinent clinical rotation. This is one of our first-year residents doing a vascular access session with one of our IR faculty the week before she was starting her first interventional rotation. This is one of our junior residents working with our breast imaging faculty on how to do ultrasound-guided breast biopsies, again, the week before she was about to start her first breast imaging rotation. It's important to have the simulation lab available 24/7. It's not enough just to offer a few simulation sessions a year. Residents need to be able to go into the lab and practice what they are taught. It's kind of like the music model. You're not going to get a violin piece the day before the performance, practice it 1 or 2 times, and then perform. You're going to practice multiple times, day and night, to do your violin piece. The same thing goes with doing procedures. Residents need to be able to go in and practice intermittently to maintain their skill set, and the trained resident super users can be very helpful to assist residents in the lab. Again, most of us need to practice. We just aren't that awesome. We also have contrast reaction simulation as part of our curriculum. Our advice, if you haven't done this before, is to get help from a program that has. A shout out to Penn State Hershey, who came down as visiting professors to help us start our contrast reaction simulation. Most programs, and we do, typically use a high fidelity mannequin with a real code cart for these simulations. Most medical schools have these, so you don't have to purchase them. This is what our contrast reaction simulation mannequin looks like. His name is Reggie, named after our chair. He opens his eyes, he talks, he has an IV where you can open the code card and inject IV epinephrine, and this has been a very successful and valuable simulation experience. We do this every August for all of our residents, and we now do it every March for our faculty, because guess what? The residents aren't the only ones who can benefit from SIM. So in summary, our recommendation is to start small. Start with the common procedures that all radiologists should be able to do and do a contrast reaction simulation. You can always add simulating many other things after you've done this. And as the great poet from Wake Forest, Maya Angelou, would say, nothing will work unless you do. Thank you for allowing us to present this information, and here are some references for you. Thank you.